Started, it would be good to keep us on time, I think. I'd like to welcome you to this morning's Department of Medicine Grand Rounds. And I'd like to just take a moment to make a comment. This is the inaugural lectureship of the Jacques Bourgonje Featured Speaker Series in Nephrology. This will occur every year. This is a special one because it's the very first year. This lectureship was established by friends, family, and former fellow trainees of Jacques Bourgonje, who came together to establish this to mark his legacy and the contributions that he made to the University of Miami School of Medicine over the many years that he was faculty here. During his years as the chief of the Division of Nephrology, he took his experiences from prior parts of his life as a physician-scientist and brought that here, expanded his role as a clinician, and really set the stage for what became a very period of explosive growth in the Division of Nephrology during the years he was leading this division, which included rapid expansion in our dialysis population of patients we cared for, an initial commitment to, and then subsequent very rapid growth in the kidney transplant program here at the School of Medicine and Jackson Memorial Hospital, and similarly a rapid and strong commitment to research, both clinical research and basic science research, as he had an appreciation for both. And in fact, he was personally responsible for bringing several large NIH trials here, the modification of diet and renal disease and the African American study of kidney disease, to the University of Miami, two very important and famous nephrology clinical trials. And as an anecdote, Jacques was one of the first describers of what became to be known as HIV-associated nephropathy. He was at absolutely the center of the description of that disease when no one knew it was a disease. He was, if you look back, you would see his name over all those papers. To me, the most important thing about Jacques, however, was the way he treated people. He epitomized to me what an academic physician should be, and he treated everyone that he came in contact with here with respect and dignity, including the faculty, the patients, staff, anybody at all. This is the man that he was. And I think this is a tremendous, appropriate honor. I want to thank his family for being here today, of course, but I also want to thank his family for, especially Chantal, for sharing Jacques with us for many, many years, especially in the later years when I know you wanted to get him out of here, and he finally agreed with you. But it was wonderful for the years he was here, and we remember that today with this lectureship.
So the featured speaker today will be Dr. Vito Campese. He's the chief of the Division of Nephrology and director of Hypertension Center at the Keck School of Medicine. Dr. Campese graduated medical school from the University of Bari summa cum laude and did his internship and residency at Policlinico in Italy before attending the Keck School of Medicine on a fellowship in 1974. During his career at USC, Dr. Campese has established himself as one of the most prominent nephrologists in the field. He has published over 220 peer-reviewed papers in his long and distinguished career. His research has focused on the impact of sympathetic nervous system overactivity in the pathogenesis of arterial hypertension. In addition, he has published extensively on his work involving animal models of neurogenic hypertension. In addition to his numerous academic and administrative appointments, Dr. Campese is a former president of the Italian-American Society of Nephrologists and is currently a member of the program committee on the Council of High Blood Pressure Research for the American Heart Association. He has been recognized with numerous awards, including honorary membership in the Italian Society of Nephrology, the Rotary Club International Contribution to Science Award, just to name a few. Please join me give a warm welcome to Dr. Campese as he presents on the environment and the kidney.
Thank you.
Thank you very much, and good afternoon to all of you. It's indeed a great pleasure to be here, and I'm very honored to be the first speaker in honor of Jacques Bourgoigny. I've known Jacques. How do we change this? Yeah, this one. Okay, thanks. Oh, this to go? Okay. I've known Jacques, and I'm honored to be here today to honor him. I was a week ago I heard the bad news that the previous chief of cardiology at USC, the university where I work, Shabuddin Rahimtullah, for the cardiologists in the room, I'm sure you know him. He's really well-known internationally and nationally. He passed away, and I was making rounds with resident fellows, and I said, he, by the way, taught at USC until 2 years prior to passing. And I asked the resident fellows, do you know who Shabuddin Rahimtullah is, who he was? Nobody knew about him. Okay. So I think it's very essential to establish these type of lectureships, to maintain the memory of people who have so importantly contributed to an institution like Jacques. Jacques is well known for his work not only in HIV, where he was one of the starters, but also has contributed tremendously in the field of bone metabolism, potassium metabolism, and fluid balance in chronic kidney disease. So it's a very well-known figure. It's essential that we remember these people who have contributed to our knowledge and to science in our institutions. But let me get to the topic of today. And I'm going to start with the Big Bang, 13.8 billion ago. That's where everything started. To go to the human beings that is the Homo erectus, he developed only 1.3 or 1.5 million years ago. And the Homo sapiens, where we derive from, he appeared only 200,000 years ago. 13.8 billion years, and only after 13.7998 billion years, the man appears in the universe. So very much later. Of notice is the fact also, you can see here, that the Neanderthal that was thought to be our ancestor actually was not, because it was a branch of evolution that has completely disappeared. Meaning species can disappear, like the Neanderthal hominids completely disappeared, but I'll come back to the importance of this concept later. So man and environment are totally interlinked in a dynamic, but also in a fragile equilibrium. Human beings have always struggled to survive, okay, and they've utilized nature to survive for many millennia. On the other hand, human beings have had initially a minimal impact on nature, but in the last few years, and particularly more recently, the human beings are having a much more significant impact on nature. So the human species evolved from, as we said, humanoids from about 2.5 million years ago. The Paleolithic age, during the Paleolithic age, human beings lived of whatever they could find in nature. Right? They would kill animals to get proteins, but primarily they would take whatever vegetables or whatever fruits were available in nature, like the animals live today, or utilizing what's in nature, unless the animals are grown by us. And we have to come, the first revolution in the evolution of human species appeared with the Neolithic Ages, 10,000 years ago, when humanoids realized in order to survive and to increase the number of population, it was not enough that they went around looking for food. And they learned that they had to develop agriculture, to seed seeds and develop agriculture. So the first revolution in the evolution of animal species really occurs 10,000 years ago in the Neolithic, when people start developing food with agriculture, development of agriculture, and also domestications of animals. And modern civilization starts 4,000 years ago when human beings develop, when we have the Bronze Age in Mesopotamia, and then the Iron Age, and then everything else that came after that, okay? Now, during all these phases, people still continue to live of domesticated animals and food that they were to produce naturally, okay? So agriculture was the essence of our evolution. Now, we talk about migrations these days, become a very popular topic in the United States, but also in Europe. In Italy these days, it's a big topic. We forget that everything started in Africa, and then because of changes in climate, people had to migrate because they couldn't survive where they were. 100,000 years ago, they went into the Middle East, and then they went to India, all this part of the world, 70,000 years ago. They reached Australia 50,000 years ago, Europe only 40,000 years ago, and they were in what's now called China 25 years ago. They reached the United States way, way, way later, way, way before Columbus went to the United States, 15,000, 12,000 years ago. So everything started in Africa. Migrations have always been a necessity for survival in human civilization. So it's nothing new. People tend to move wherever there is more food, there are more opportunities. Now here during Mesopotamia ages, 10,000 years ago, there is evidence of a domestication of animal, use of animal for food feeding. And in the Egypt era, here's the Giza pyramid, 1,200 years ago, we have evidence that, again, there was agriculture well developed during these phases. So the development of relationship between human geography has a second hit, or a second revolution occurs only 250 years ago when the world changes completely. The industrialization initiates 250 years ago, roughly. In the 18th century, there is a second revolutionary leap that leads to development of machinery to help again in the production chain. It's called industrial civilization. In the 19th century, we develop the human developing thermal combustion engine, use of electricity. Humankind starts attempting to control nature. It's a big change in humanity. Humans used to be dependent like other animals on nature. 250 years ago, we start thinking that we can control nature. And then we go to the third stage of the Industrial Revolution, the 20th century, where we develop non-renewable fossil fuel energy, electronic computers, space technology. From manual labor, we go to machinery production. The results here in a tremendous increase in productivity, increasing wealth, but also new forms of environmental pollution, such as plastic, noise pollution, automobile exhaust, light and electromagnetic pollution, space junks, nuclear radiation, and so on and so forth. This occurred all of this very, very recently. And now we are in the fourth industrial revolution, whereby robotics, artificial intelligence, nanotechnology, quantum computing, biotechnology, the Internet of Things, 3D printing, automated vehicles, and you name it, all right? Now, another revolution I want to talk about, which is important, is the Green Revolution. I don't know how many of you have heard about the Green Revolution. It started in the 1950s, 70s. The aim was to feed billions of starving people in the world. The problem is still existing nowadays. And Norman Borlaug was an American agronomist who eventually got the Nobel Peace Prize in 1970. He was the leader in this process. He said, how do we feed people who are starving in the world? And he had the idea of, and he had this motto that the first essential component of social justice is adequate food for all mankind. And so he embarked in this effort to increase production of food through chemical fertilizers, agrochemicals, pesticides, herbicides, improved irrigation, mechanization, yielding also hybridized seeds for a variety of cereals in order to improve the productivity of cereals. And this initiative had a tremendous impact on health worldwide. It is estimated that this effort saved over $1 billion people from starvation. It was not a minor impact. It did not have a minor impact on civilization. Tremendous impact. This was great. But at what price for the environment? Well, this is the price that industrial civilization, the green revolution have brought to our society. These are our cities, how they look today. This is in China. This is China in a bad day and a good day, all right? And these are our factories, and these are our agriculture dust exposure has increased tremendously. So, continuing increased rate of exploitation of natural resources, industrialization, technological growth, and unplanned urbanization are responsible for grave environmental crisis. The human beings are changing nature for the first time in history. And this is creating huge problem. Global warming is one of these problems. I know some people still don't believe in global warming. Our president doesn't. But there has been over the evolution of species, there have been phases where temperature has changed naturally, all right? You look at here, level of sea that correlates nicely with temperature increase. There have been phases during history where temperature has gone up, then has gone down, gone up again, gone down again. 25,000 years ago, we had another glacial age, so-called glacial age, where people had to migrate from some part of the world to other parts of the world because they couldn't live because of temperature. Now, during the last 10,000 years or so, temperature has been going up and up and up and up and up. So, what we are witnessing now, it's a natural phenomenon, or it's something we are contributing to it, and science tells us that we are badly contributing to speeding up warming temperature of the globe. Now, as I said, some still don't believe, our president does, even though there is uncontroversible proof that the global warming indeed exists. Somebody should send this slide to President Trump. But be careful. Nature is vengeful against those that try to subvert him. Many animal species have been totally wiped out. The Neanderthals have been totally wiped out from Earth. Even the powerful dinosaurs, the Neanderthal, humanoids are no exceptions. So unless I think human beings are careful what they are doing, they may pay a big, big price. But let me come now to the kidneys, which is the topic of the day. All right? What is the impact of this revolution, first of all, on public health and then on the kidneys? Well, on public health, we have had tremendous transformations. If you look at the world population has increased from 10,000 when the Homo erectus developed to about over 7 billion. In 1800, there were only 1 billion people. Now we are 7 billion. Over 200 years or so, the population has increased 7 times. Average life has increased tremendously, and part of this increase in population is due to the fact that people are living longer, but that's not the only answer. So this looks all good, all right? We are living longer, more people on Earth. And in fact, if you look at Western countries, in 1840, the average life expectancy was roughly 45 years. Over a period of 200 years, we have gone on average life expectancy of 84 years or so, depending on the country. So tremendous good impact on public health. However, what are the bad side of all of this? Well, with the Industrial Revolution, lifestyle has become more sedentary, leading to more obesity, more diabetes, more hypertension. Environmental changes, all these things we have pointed out, have created new health threats, and also new medicine and diagnostic agents have contributed to polluting, to poisoning human beings. WHO estimates that 92% of the world population lives under conditions of air quality that is below what's considered acceptable. 92%, so means almost all of us. In Europe, it is estimated the exposure to excessive particulate matter of 2.5 micrometers cause more than 400,000 premature deaths per year. In China, in 2010, there were 1.2 million premature deaths, probably caused by exposure to poison, environmental poison. And this represents a 42% increase than 10 years before. So in only 10 years, 42% increase in mortality due to exposure to poison. So the kidneys now. The kidneys are particularly susceptible to environmental factors. Why? Well, the kidneys have a huge blood flow. The blood flow is necessary for the filtration, primarily for glomerular filtration. The kidney receive about 1,200 ml per minute, which is 25% of cardiac output per minute. 50% higher than what is needed in other organs and what is needed for oxygenation of kidney tissue. The high blood flow is necessary, as I said, for glomerular filtration. However, if you look at the distribution of blood flow, 90% is in the cortex, 9% in the outer medulla, only 1% in the inner medulla. What does it mean? It means that the inner medulla lives in a condition of borderline oxygenation, even under normal circumstances. So given the secretory-excretory function, the hyperosmolality in the medulla, the low oxygenation also in the medulla, the kidneys are commonly victimized by circulating antibody-antigen complexes, and you know many renal diseases related to deposition of immune complexes, environmental toxins, drugs used for therapeutic reasons or for recreational reasons, heroin, cocaine, amphetamines. We see so many in our institution. I'm sure in Miami you see it's exactly the same thing. We expose our patients to diagnostic agents more and more and more. CT scans get done like, nothing were to be done to a patient. So all these things really expose to the kidneys to great danger, environmental danger. And there is an association also between urbanization and chronic kidney disease. The prevalence of chronic kidney disease worldwide has been going up. In the United States now it is estimated that roughly 10% of the population, 10%, 1 out of 10 have chronic kidney disease. Now some dispute these numbers, but nonetheless, the American Society of Nephrology, National Kidney Foundation, they stick to these numbers. Now, in Asia, in other parts of the world, the prevalence is just about the same. In some part of the world, it's much higher, as we will see. Now, in China, in this study, they took 44 men and 4,000 plus women, age 18 or over, and they looked at with the reduced renal function, and they saw an association between urbanization index. They have an index of urbanization. I won't bother you with it, or a level of urbanization and reduced kidney function. So living in big city, in urbanized cities where there is greater exposure to these environmental poisons, certainly is not healthy. This is a nice study done in Boston where they've looked at average GFR in population very close to a railroad station and moving forward to a railroad station. And those who live close to the railroad station had lower GFR, those who live farther away. Now, it's an association, doesn't prove causality, but nonetheless, it's an important concept. In Taiwan, another study that looked at also thousands of patients retrospectively with CKD, they follow these patients over years for an average of 3.5 years, and they notice again an association between chronic kidney disease and exposure to arsenic, cadmium, chromium, mercury, copper, lead, nickel, zinc, all the goodies that are available in our environment these days. Now, per and polyfluoroalkyl chemicals, or PFAs chemicals, these are everywhere in our environment nowadays, okay? There are over 3,000 compounds. They are used for stain and grease repelling properties. They are used for firefighters. They are used textile papers, food packaging. They are everywhere. And they've been shown to be highly toxic for the kidneys as well. There have been epidemics of kidney disease, such as the Balkan nephropathy, linked to environmental factors. Now, Balkan nephropathy is a nephropathy caused by chronic tubulointerstitial nephritis, affecting the Danube River region, Bosnia, Bulgaria, Croatia, Romania, Serbia. It occurs focally in certain families, in certain villages, and then villages close by, they don't develop the disease, very patchy disease. There is a familiarity for the disease, but no inheritance, no genetic inheritance, affects individuals older than 18 years. And there is also a strong association with upper urinary tract transitional cell carcinomas. What's causing this disease? It was unknown for a long, long time. So this is the distribution here, the regional distribution. As I said, Bosnia and Herzegovina, Serbia, Croatia, some part of Bulgaria, a little part of Romania, the southern part of Romania. So originally people thought might be ochratoxin A. What's this ochratoxin A? It's ubiquitous present in a variety of foodstuffs, including cereal grains. And studies in the endemic regions found that these people had high levels in the urine of ochratoxin A, so some put a link between the two. It turns out probably that's not maybe one of the factors of Balkan nephropathy, but it's not the main one. The main one is called aristolochic acid, okay? What is this aristolochic acid? Let me tell you a little story about this. First of all, was actually a veterinarian who first described kidney disease in horses that ingested hay contaminated with Aristolochia clematis, that is a weed that is found in the field where there is all kinds of grains. In 1967, a physician came up with an intriguing hypothesis. He said, well, since wheat grains during the annual harvest commingled with Aristolochia clematitis, why there couldn't be an association between these two things? And this was in 1967. It was ignored for 35 years. Nobody paid attention to his report until an American Grolman, who still lives, he's still at Stony Brooks in New York, he received some biopsy from people with Balkan nephropathy, and with this ultra-sensitive technology, he found the position of metabolites of aristolochic acid in the kidneys. And he said, well, it must be aristolochic acid responsible, and he has now proven the concept definitely. He also took cancers from villages where the disease was endemic, and he found a certain mutation that were present in cancer from that region, but not cancer in another region. And the mutation was on chromosome 53. You see here cell cancer from region where the disease was endemic. Large percentage of these patients, 78%, has this mutation. Cancer in region where there was no, the disease was not endemic, Balkan nephropathy, only 9% of people had this mutation. So very high concentration of this mutation in this particular region. This is the weed. That's the way it looks. I've seen this weed in farms where they grow grains. And so it's there, and has been there for a long, long, long time. Indeed, it's known that for 2,000 years, Chinese medicine have used Aristolochia for a variety of things, going from urinary tract infection to stay younger and so on and so forth, okay? And during the Roman and Greece time also, Aristolochia was used in a variety of herbal recipes without knowing that this was actually nephrotoxic until in the year 2000, after an epidemic of chronic kidney disease in Belgium, whereby women who took herbs containing aristolochic acid as a contaminant, they developed chronic kidney disease. 40+% of them developed cancer, urothelial cancer, not just chronic kidney disease. So many of them ended up on dialysis. Many of them died of cancer. So from that point on, now we know that there is a disease called Chinese herbal nephropathy due to aristolochic acid. Has been shown worldwide in many other environments, has been shown, and now goes under the name of Chinese herbal nephropathy. Now, as I told you, there is an epidemic of chronic kidney disease in the world, in large part driven by an epidemic of obesity, diabetes, particularly in industrialized countries. But there are parts of the world where there is an epidemic of kidney disease that has nothing to do with obesity, hypertension, or diabetes. Okay? Particularly in Central America, in the last 2-3 decades, Central America, but also late India and part of Africa and part of Asia. There's an epidemic of kidney disease, and nobody knows what's causing this epidemic of kidney disease. Certainly, as I said, it's not linked to cardiometabolic causes. So here are the parts of the world where this is occurring. It's occurring in Central America here. It's occurring in part of Africa, in Egypt, in Tunisia, in part of India, particularly Sri Lanka. And there are some focus also disease in Taiwan, some part of Taiwan where the disease is. In Central America, the first description was only 16 years ago. So this is a very recent thing discovered. May have been there longer, but this has been described only recently. 2002, Trabanino was the first one to report that 67% of patients with chronic kidney disease in El Salvador had an unknown cause. To give you an example, in the United States, only 10-15% of patients with chronic kidney disease have an unknown cause. Most of them have diabetes, hypertension, glomerulonephritis, polycystic kidney disease, and you name it. In that population, 67% of the chronic kidney disease, they didn't know where it came from. Subsequently, the same phenomenon was described in other countries in Central America. We'll see which part here. It's primarily in the Pacific Ring where you see these yellow spots. So you see it in Guatemala, in El Salvador, in part of Honduras, in Nicaragua, where Dr. Fornoni and I have been involved or are involved, and part also of Costa Rica, and a little bit of Panama, and a little bit in the ring of the southern ring of Mexico. So it's affecting the Pacific portion of these countries and not the Atlantic side of these countries. Now, at the beginning, people start making connection between this disease and sugarcane harvesting because they saw among people who were harvesting sugarcane, there was a high prevalence of chronic kidney disease. And this created also a big political problem in countries such as Nicaragua, El Salvador, and so on and so forth. Alessia and I have been in Nicaragua, and these people really work in very dreadful conditions because they have to burn the sugar canes a few days before, 1 day before, 2 days before, and then they have to harvest the sugar cane, they have to cut those, there is dust all over. And so the idea came that the sugar cane harvesting is causing the disease. This was the first idea. It turns out that the idea is not correct. Because, yes, the disease occurs in the Pacific Ring, this has been confirmed, but it affects not just people working in sugarcane fields, but also miners, people in construction, fishing industry, port workers, brick makers. It affects primarily males, but it also affects females, and may affect children. Children in mid-school, actually, have been tested, and they have already signs or increased frequency of chronic kidney disease. What is the presentation of this disease? Well, I'll come in a moment. I'm showing you this survey that was done by 2 Italian guys, actually. It's not published these days. There was a randomized survey of a small town of 26,000 people. The town is called Malpaisio. And they randomly selected 10% of the population, and they looked at the prevalence of chronic kidney disease. And they found that 27% of people in that part of Nicaragua. They had chronic kidney disease, high prevalence of hyperuricemia. They found a very significant association between uric acid levels and chronic kidney disease. Interestingly, the urinalysis shows only minimal proteinuria, some leukocytes, but and many of these patients do not have significant hypertension. So, it's more common in men than in female. The prevalence increases with aging as expected. It's primarily at sea level. Up in the hills, at least in this survey, there was very little prevalence of the disease. So it's primarily down in the basin, not in the hills, and affects men more than women, but women are affected as well. The presentation is usually progressive reduction in GFR, normal, mildly elevated blood pressure, as I mentioned, low-grade proteinuria, hyperuricemia, hypokalemia. These are features. Hypokalemia probably may be related to a component of renal tubular acidosis. Histologically, they all have tubulointerstitial nephritis. Glomerular in them. They're fine. Some may become sclerosed, secondary sclerosed with time, but primarily the disease is a chronic tubulointerstitial disease. A researcher in Houston, Christy Murray, she has described cases that present also with acute kidney injury, with acute deterioration in renal function. They usually, again, predominantly they are males, less females. They may present with fever, nausea, back pain, vomiting, headaches, weakness, and they present with an increase in creatinine. Most of them recover quite rapidly. Many of them go on, probably 10% of them goes on to develop progressive deterioration in renal function, chronic kidney disease, according to Christie. A urinalysis shows some leukocyturia, shows leukocytes cast, some bacteriuria, and biopsies that have been done in these patients show exactly the same thing. Again, acute tubulointerstitial nephritis. In some patients, there was some level of chronicity, but primarily you see all this infiltration of plasma cells, lymphocytes. And the big question is, what's killing these young workers in Central America? And as I said, it's not Central America, it's also Sri Lanka, other parts of the world. It remains a big history, but there are some theory, and I'll show you what the latest on what we know now about this disease. The first explanation of why this disease was given by Correa Rotter, who thought that these patients developed the disease because they work under condition of extreme heat, they sweat a lot, they become easily dehydrated, so the volume depletion may indeed cause ATN or tubulointerstitial nephritis. Some of them, because of the heat, severe extreme labor and the heat, may develop some degree of rhabdomyolysis, contributing also to tubular injury. Heavy metals, agrochemicals they may be exposed to may also be contribute to this. Also, these patients, because they have aches and pains very easily, they work very, very hard. They use NSAIDs quite commonly. They drink alcohol made like we in the United States people used to make moonshine, i.e. distilling in lead containers, and so lead poisoning may contribute to this. And all this, some infectious component may cause this, according to Correa Rotter. All these factors combined may cause chronic tubulointerstitial nephritis. So the disease may be multifactorial. There was this hypothesis, okay? Is there any evidence of an infectious cause? We have been, Leslie and I were in the fields, and when you walk in the fields, you see a lot of rats, dead rats. They've been burned when they burn the crop. And leptospirosis is very endemic in that region. It's endemic among rats. It's endemic also among people. So the first thing, of course, particularly Christy Murray in Houston, she thought the leptospirosis may be responsible for these things. Antivirus was another candidate. But in the study done by Christy Murray, it turns out that if you look at the prevalence of people who had no antibodies to leptospira antivirus, 41%. Those who had antibodies to leptospira, 40%. Those who had antibodies to antivirus was a small percentage, and combination was a small percentage. So almost half had antibodies, and half did not have antibodies. And the general population, about half of them have antibodies. So no evidence really that leptospirosis was responsible for this. As I mentioned, they use a lot of NSAIDs, acetaminophen, paracetamol, and that certainly could be a contributing factor. Another hypothesis that was proposed more recently by Richard Johnson in the American Journal of Kidney Disease had to do, yes, with volume depletion causing acute renal tubule damage, but also had to do with the idea that hyperuricemia that you always see when a patient is volume depleted. Richard Johnson has always considered uric acid as toxic to the kidneys, and in a certain extent it is, but it has to be quite high, all right? And then it's postulated also that the drinks that these people drink, very overloaded with fructose, may also contribute to renal tubule damage and a progressive kidney disease. So the idea here, the major hypothesis is dehydration is the major factor responsible for chronic kidney disease, and perhaps the use of fructose in soft drinks may be a contributing factors. I interjected with him, and we wrote two editorial on this problem. My idea was it was not dehydration responsible for this, actually was rehydration. Okay, and let me explain what I mean by that. Certainly they are dehydrated, they sweat a lot. I mean, they have to drink a lot of amount of water, and obviously dehydration leads to reduced perfusion, concentrated renal medulla, and may lead to renal damage, no doubt about that. But my idea was, and it is, it remains, these people, in order to keep up with losses in a day, guess how much they have to drink? Give me a number. 4 liters? 6 liters? Anybody takes 8? Nobody takes 8? Make it 10, 12 liters of water per day. All right? So, the idea here has always been to measure concentration of poisons in the water, in the drinking water, and they primarily drink water from wells. And you can find a little bit of this, a little bit of that, a little bit of cadmium, a little bit of nickel, a little bit of lead. Arsenic has been found in some wells as well. But they do not reach the so-called levels, toxic level of the drugs, all right? The point is, though, if you drink 10 liters of drug containing these poisons in an environment, a kidney environment, where you have an over-concentrated kidney, you are exposing the kidney to accumulation of toxin in the tubules that may lead to renal damage. So, my hypothesis has been that is rehydration with the wrong water the problem. Hence, you have to change what they drink. Okay, because they are going to drain. You have to change what they drink. Now, we are testing that. We still don't know who is right, who is wrong. But that's where we are from this point of view. Let me tell you what's come new, what is new, known now. And this is all unpublished, by the way. There was a big meeting at the NIH in June of this year on this topic, and there were more than 200 people participating. It's a huge social problem. Felt, as I told you, in many parts of the world, not just Central America now, because other parts of the world have the same problem. Well, I met in Washington, D.C., a guy from Belgium, by the way, the same country as you are, and the Broad, who has taken kidney biopsy from people that come from these endemic areas, and he has found that certain lesions, which I'm going to show you in a minute, lysosomal lesions, they are very reminiscent of lesions caused by cyclosporine that we use as immunosuppressive agent on lysosomes. Aristolochic acid does not cause this type of lesions. Dehydration does not cause this type of lesion. So, and these are the lesions here. These are renal tubule cells showing this lysosome, huge lysosome, and this is electron microscopy, magnified electron microscopy. It shows these strange lysosomes, which are huge, with the electron density matrix here along the microsome. And these are lesions, again, as I said, identical to what you see if you give cyclosporine for a long time to a patient. So the idea, these data are been submitted and accepted by Kidney International, should be published this month or next month, okay? So the idea really, by the way, he has taken samples now, the bro, from coming not just from Central America, but from certain part of France, Sri Lanka, certain parts of Peru, all with chronic interstitial nephritis, all in similar laboring conditions, and he found the same lysosomal alterations that I've shown you in all these regions. Calcineurin, as you know, is an important component in immunological cascade that activate NFAT. It is a transcriptional factor important for activation of T cells. And we use the inhibitors of calcineurin to really block production of proliferation of T cells clinically. Well, as you know, calcineurin is intrinsic in the calcinuric medical activity or good activity, the fact that it's nephrotoxic. So, indeed, a calcineurin inhibition can cause to kidney abnormalities. Well, what's the link between now calcineurin and the Mesoamerican, what we call Mesoamerican nephropathy? Well, all insecticide type B parathyroids are potent inhibitor of calcineurin, and these are used as agrochemical very, very commonly. Paraquat, that is an herbicide, increases production of hydrogen peroxide, and hydrogen peroxide also inhibit calcineurin phosphatase that activates NFAT, as I showed you earlier. Paraquat also ultimately inhibits calcineurin activity. And there are also some chemotherapeutic agents, nothing to do with nephropathy, nothing to do now what we are talking about, that also can inhibit calcineurin and also have been shown to cause interstitial nephritis. So it's at least a starting point where we are now looking at whether there is a combination, an association between calcineurin inhibition and the nephropathy that we are seeing in these patients. And we are looking now, once again, in the water, we are looking in nails, concentration in nails of heavy metals as well as chemicals. Another last story I want to talk to you about is glyphosates. Glyphosates have been banned, are used in the agriculture very, very commonly. They speed up the maturation of crops. So they are, it's used to irrigate crops 10-15 days after harvesting. It speeds up that process. Well, they've been banned in many countries in Europe, including in Italy. And they're not been banned yet in the United States, strangely. But in Sri Lanka, they've shown actually that in the fields where they use glyphosate, there is very high prevalence of chronic kidney disease. And the theory they've come up with is that you need two factors for glyphosate to be damaging. One is the glyphosate that you irrigate the water, and the other one is to drink hard water. If you drink soft water, nothing happens. This complicates issues because it tells us that you may have 2-3 factors that may be working synergistically to cause damage. All we are looking at is the concentration of lead or cadmium, nickel increasing the water or whatever, when in reality you may have acceptable concentration of something that works synergistically with something else to cause kidney damage. And indeed what they have shown is that, I don't know whether you can read this, And if you, in normal water, glyphosate, in people who drink normal water, you produce certain metabolites which are not nephrotoxic. If these people, on the other hand, drink hard water, you have a production of tridentate ligand, which is highly nephrotoxic. So it makes the things more complicated, but nonetheless, it tells us how complex this issue may be. So, in summary, the symbiosis between human and environment has become precarious. A growing number of diseases are caused by environmental factors. The kidney is particularly susceptible to environmental factors, and an epidemic of CKD of enormous proportion is affecting several regions in Central America, Asia, and Africa. The disease affects primarily young workers. Mostly of these people we see are 20, 30 years old, 35 years old. They are subjected to strenuous heat, to strenuous working conditions, so dehydration certainly may be a component of the problem. The disease can progress rapidly. We have shown you some patients may have acute kidney injury, and some may progress rapidly. Most of them progress more slowly. The causes remain unknown, but certainly environmental toxins, in conjunction with dehydration, appear to be critical factors. And then the big question now, thanks to the work of the board, is calcineurin inhibition a common pathogenic pathway? Because if that is confirmed, then we can start looking at ways to perhaps antagonize this action at the levels of calcineurin. These are our ancestors. We are deriving from them, and they are challenging now us on the field, the soccer field, to see who is winning the battle, who is going to survive longer. Are they going to survive longer, or we are going to survive longer? And unless we really come to grip with the idea that the environment is sacred and we need to preserve the environment in a much better way than we have been doing, that we may be extinct, not tomorrow. It's not going to affect us. But who knows, in 1,000 years, 2,000 years, 3,000 years, the history of humanity, it's hundreds of thousands of years. Are we going to extinguish ourselves just because we are not careful about what we are doing? Thank you very much for your attention.
Thank you very much, Dr.
Thank you.
We have time for one quick question. Anyone who has any? Oh, yes.
What's being done for management?
Nothing. All we have done, because we don't know. Yeah, the question is, what are we doing for management? And the reality is, we don't know what's causing this. So we are trying to do in Nicaragua. We have gone in the fields, and we have actually imposed on the owner of these factories, huge factories for sugarcane, that they purify the water, and they are doing that. So we have told them they have got to provide water. They do some sort of purification, but they remove only calcium, magnesium. They don't purify the water. So now they are implanting RO system to purify water and provide workers with purified water. That's the only thing we are addressing right now. Obviously, if we were to understand the pathophysiology better and confirm this idea about calcineurin, then there are other things that need to be done. But certainly, in my view, water is probably one of the main components here of the equations. Because if the water is contaminated, added that to dehydration and other things, it may be causing the problem. So that's the direction we are taking now.
I want to thank our speaker, and most importantly as well, the family, the Borghinis, who have been so generous in sponsoring today's lecture and making this possible. Thank you, both of you.
Thank you very much. Thank you. Thank you. Good night.
Marcel Nimni.
Marcel?
Nimni at USC.
Which department is he?